All right, let's get right into it. If you're a nursing student, you are in exactly the right place. Today, we're doing a super fast, high-yield review of labetalol, and we're going to cover precisely what you need to know for your exams and, more importantly, for safe practice out on the floor. Okay, let's kick this off with a scenario that's all too real. Your patient is in a hypertensive crisis. The doctor orders labetalol IV push, stat. What you do next, well, it has immediate consequences. So what are the absolute must-knows before you even think about pushing that drug? Stick with me, and by the end of this, you'll know the answer cold.
So first things first, what in the world is labetalol? If you don't understand what a drug is at its core, you can't predict what it's going to do, both the good and the bad. And labetalol, well, it's a pretty unique kind of blocker.
And here it is. Labetalol is both a selective alpha-1 blocker and a non-selective beta blocker. That phrase, dual action, that is everything. It means this isn't just another run-of-the-mill beta blocker. Nope, it's fighting the battle on two different fronts at the same time to get that blood pressure down.
This right here breaks down that dual action perfectly. So on one side, you have the alpha-1 blockade. This basically tells the blood vessels to chill out and relax, which causes vasodilation, and that lowers resistance. Then on the other side, you have the beta blockade, which slows the heart rate down and makes it pump with less force. See? Both actions have the same end goal, lower that blood pressure. It's a really powerful 1-2 punch.
So we know what it does. Now for the really important part. How does this actually play out in our practice? How do we give it safely? This is where your role as the nurse is absolutely critical. And I promise you, these steps are pure NCLEX gold.
Okay, look really closely at this list. Number 2, keeping the patient supine is non-negotiable. And we're about to see exactly why in just a minute. Number 3, pushing it slowly over 2 full minutes. This is what keeps that blood pressure from just bottoming out. And number 4, checking those vitals before and then again at 5 and 10 minutes after. That's your real-time feedback. That's how you know how your patient is responding. These aren't just suggestions, they're your safety net.
Okay, we've given the med correctly, but our job is not even close to being done. Now we have to ask the big question. What could go wrong? This is where your nursing surveillance, your spidey senses really kicks in, watching for any sign of trouble.
Let's start with the things that can happen fast. I mean, really fast. These are the rapid onset red flags, the life-threatening reactions you have to be ready for the second that drug enters the bloodstream.
Listen up, because the most critical point on this slide is bronchospasm. So why does this happen? Remember how we said labetalol is a non-selective beta blocker? Well, it doesn't just block the beta-1 receptors in the heart. It also blocks the beta-2 receptors in the lungs, the very ones responsible for keeping the airways open. So if your patient has asthma or COPD, giving this medication could be catastrophic. It can cause an immediate airway emergency. This is probably the single most important connection you need to make with this drug.
Now, while bronchospasm is one of the scariest and deadliest risks, it's not actually the most common major problem you're going to run into. There's one side effect that happens with pretty alarming frequency, especially with the IV form.
58%. Let that number sink in for a second. According to the data, up to 58% of patients who get IV labetalol can experience orthostatic hypotension. That is more than 1 out of every 2 patients. This isn't some rare footnote side effect. It's a common, almost expected problem that you have to manage proactively.
And boom, this quote right here is the why behind our strict administration rules. That huge 58% risk of orthostatic hypotension, that's exactly why we keep the patient flat on their back during and after we give the med. It's why we don't dare let them sit up or stand until we are absolutely sure they can handle it. This is a fundamental, core safety principle.
But your surveillance doesn't stop after the first 15 minutes. Nope. Some of labetalol's most serious risks are slow burners. They can take time to show up. So let's look at the delayed dangers.
These are the things you're going to be watching for over hours and sometimes even days. First, you're on the lookout for hepatotoxicity. That means you're monitoring their liver enzymes like AST and ALT, and you're looking for physical signs like jaundice. Second, you're assessing for any new or worsening signs of heart failure, checking for edema, listening for crackles in the lungs, asking about shortness of breath. And finally, you're keeping an eye on that cardiac monitor for any signs of an AV block, like a brand new prolonged PR interval. This is all about long-term vigilance.
Okay, let's switch gears and talk about a special population that always seems to pop up on exams: patients who are pregnant or lactating. This is a situation that requires an extra layer of caution and some very specific nursing actions. The key takeaway here is actually pretty simple.
The drug crosses the placenta. So if mom gets it, you better believe the baby is getting it too. This means your job as the nurse after delivery is absolutely crucial. You have to monitor that newborn for the exact same side effects you'd watch for in an adult: a drop in blood pressure, a slow heart rate, low blood sugar, and any trouble breathing. Whew! All right, we have covered a lot of ground. So let's bring it all home with a rapid-fire recap of the absolute must-know high-yield facts you need to have locked in for your exam.
This is it. If you remember nothing else from this, remember these 5 points. 1. It's a dual-action blocker. 2. When you give it IV, your patient must be supine. 3. The biggest risk is that massive 58% chance of orthostatic hypotension. 4. The deadliest risk is bronchospasm, all because it's non-selective. And 5. In pregnancy, your focus has to shift to that newborn as soon as they're delivered. Got it?
Okay, I'll leave you with one final question just to make sure this is cemented in your brain. Thinking back to that whole non-selective beta blockade thing and what it does to the lungs, what common respiratory condition in a patient's history should make you slam on the brakes and question this order? The answer, of course, is asthma or COPD. Making that connection, from the drug's mechanism to the contraindication, that's the kind of critical thinking that takes you from being just a student to being a truly safe nurse.